Good afternoon, everybody. Today we shall start with intersexuality or ambiguous gender. So, chromosomal basis of sex determination is the sex of fetus is normally determined at fertilization. The cells of normal female contain 2X chromosomes, and that of normal male contains 1X and 1Y. That is XY. During the meiotic reduction, half of the male gametes receive a Y chromosome and other of an X chromosomes. Because a female has 2X chromosomes, all female gametes contain an X chromosome. Chromosomal basis of sex determination, abnormalities of meiosis and mitosis. Errors in meiosis and mitosis result in any of the following principal effects. They are, as such, an extra sex chromosome, an absent sex chromosome, two cell lines having different sex chromosomes and arising by mosaicism. Two cell lines having different sex chromosomes and arising by chimerism. Then, a structurally abnormal sex chromosomes and sex chromosome complement incoincident with the phenotype. These 6 variants are possible in chromosomal basis of sex determination. Things to be known before knowing about intersexuality. They are principles of sexual differentiation, sexual organ development, components contributing to determination of sex. Coming to the classification of intersex, so first from the indifferent gonad, the testis, HY antigen and Y chromosome, when there is cortical regression and medullary proliferation, it will give rise to testis formation. The testis releases testosterone, in turn produces 5-alpha reductase and dihydrotestosterone. Then the development of male axonal genitalia occurs. Then testosterone, development of Wolffian duct will have. Then the testis Mullerian inhibition factor, Mullerian inhibition factors leads to regression of Mullerian duct. So here entirely the testis develops and the chromosome is Y and XY, X to Y antigens. So thus the testis forms. So if the ovary has to develop, the lack of Y testicular determinants, they lead to cortical proliferation, whereas in testis formation, cortical regression occurs. In ovary formation, cortical proliferation occurs. Hi, Kumar. Kumar. Raman Rai, or no, set chair. Then, while development of the ovary, absence of testosterone and absence of Mullerian Mullerian inhibition factor. In the absence of Mullerian, absence of testosterone is there, absence of Mullerian inhibition factor is there. Thus, the development of Mullerian duct develops, and the regression of Wolffian duct, development of female external genitalia. So, here, when the Wolffian duct develops, it promotes testis, where development of Mullerian duct, it promotes ovary. So, development of female external genitalia does occur by the development of Mullerian duct, regression of Wolffian duct. Thus, the development of female external genitalia occurs. Then, classification of intersex gender identity disorders associated with normal sex chromosomes, female pseudohermaphroditism, male pseudohermaphroditism, and organ defect. And coming to abnormal sex chromosomes, this what I discussed is regarding normal sex chromosomes. When the abnormal sex chromosomes comes, sexual ambiguity infrequent, and Klinefelter syndrome, Turner syndrome, double X male, pure gonadal dysgenesis occurs. Sexual ambiguity is very frequent. In that, mixed gonadal dysgenesis and true hermaphroditism occurs. Clinical presentation of diagnosis of intersex is ADRENOGENITAL syndrome in ambiguity of sex at birth. This is diagnosed by sonographic evaluation of internal genital organs, karyotype where 46XX will be seen, and serum 17 hydroxylase and urinary progesterone, urinary pregnenolone is elevated and less than 5 milligrams per 100 ml. Then coming to mild form of ADRENOGENITAL syndrome, virilism and amenorrhea at puberty occurs, and karyotype is 46XX, and serum 17 hydroxyprogesterone is elevated. And masculization is ambiguity of sex at birth. Masculization due to androgen excess in maternal circulation that leads to ambiguity of sex at birth. History of drug intake, karyotype 46XX, and serum 17 hydroxyprogesterone will be normal. Unlike the above conditions where serum 17 hydroxyprogesterone is elevated. And coming to the gonadal dysgenesis, that is Turner syndrome, the symptoms will be primary amenorrhea, poor secondary sexual characters, short stature, webbing of neck, cubitus valgus, and genitalia underdeveloped. They are not fully developed. And this is, we can diagnose by sex chromatin 46XO, bilateral streak gonads, and serum E2 decreases and FSH is increased. Coming to the mosaic Turners, this is from primary amenorrhea, then average height, poor secondary sexual characters, genitalia underdeveloped. This is mosaic Turners, and sex chromatin in this case will be 45XO or 46XX, and bilateral streak gonads will be seen. Coming to your pure gonadal dysgenesis, the delayed secondary sexual characters, average height, genitalia underdeveloped. And this is diagnosed by sex chromatin 46XX or 46XY and bilateral streak gonads. And coming to mixed gonadal dysgenesis, at birth, ambiguity of sex, at puberty, virilism with amenorrhea, and external genitalia partly masculization. Internal genitalia may be unilateral Mullerian. These can be diagnosed by karyotyping 46XO 46XY. Testis one side streak gonads, testis on one side and the streak gonads on the other side. Then coming to the testicular feminization. Here primary amenorrhea will be the symptom, and infertility phenotypically female, breast development is good, external genitalia normal. In this, the axillary and pubic hair scanty or absent, short blind vagina, gonads labial fold, labial, vaginal or abdominal. Gonads labial, vaginal or abdominal. Gonads are seen in the labia or in the abdomen. This is testicular feminization, and karyotype will be 46XY. Gonads are testes. Klinefelter syndrome, unicoid, infertility and gynecomastia are the symptoms. The external genitalia will be male, gentile ducts or Wolffian ducts. So sex chromatin is positive, karyotype XXY. In true hermaphroditism, ambiguity of sex at different phases of early cycle. Sex chromatin is usually 46XX, maybe 46XY or 46XX or 46XX or 46XY. Gonadal biopsy is confirmatory for the true hermaphroditism. Amenorrhea is a common. Ootests are seen. Then coming to male pseudohermaphroditism. X-linked recessive inheritance has a strong family history. These people look like females. Phallus usually developed with hypospadias. Hypospadias means the urethral opening will be under the penis. Epispadias mean above the penis. So testicles undescended and maldeveloped. Shallow vagina may be present. Usually reared as females. Diagnosed when inguinal area shows presence of testis. Male pseudohermaphroditism with undescended testis. As soon as we diagnose testis, either in the abdomen, the inguinal region, or in the labia, we have to remove the testis surgically. Otherwise, they are going to land in for malignancy. So, as soon as we diagnose, we must remove the testis. Otherwise, they will turn into malignancy. Treatment is gonadectomy in childhood to prevent development of malignancy and hirsutism. Estrogen during puberty will help to growth of breast. Surgical correction of external genitalia. That means we have to reform the vagina whenever she is going to get married. Otherwise, even if we reform, it is likely to get occluded. So, before her marriage, we have to create a vaginal canal. That is vaginoplasty we have to do. We have to take a skin graft from the thigh, medial aspect of thigh, and we have to create a vaginal opening. She may not conceive, but she can enjoy the sexual life. Rear the child according to the phenotype of sex after removing the gonads. Due to enzyme block at the level of 17-hydroxyprogesterone, external genitalia are masculine, internal genitalia are feminine. So treatment is cortisone, synthetic steroids, external genitalia restored to feminine type by plastic surgery. Then surgical removal of the tumor, maintenance of estrogen and progesterone. Coming to Turner syndrome or ovarian agencies or gonadal dystosis. Syndrome with streaky gonads, no graphene follicles in the ovary, so estrogen not produced. In this, nucleus possesses only 45 chromosomes with genotype X1. Absence of Y chromosome resembles females, but these patients are like males. Features of the patient will be short stature with webbed neck, breast not well developed, pubic hair and axillary hair are scanty, vagina, uterus are present but they are underdeveloped. Corporation of aorta is generally associated with these patients. And high palate, low set ears, deafness, and lymphedema are the other common signs what we find in Turner syndrome. Treatment of Turner syndrome. Coming to the treatment and management of Turner syndrome, estrogen. Here, the patient will have poor beard growth, breast development, and underdeveloped testes. Characteristic facial features are web of skin, constriction of aorta, poor breast development, underdeveloped ovaries. Here, the treatment is estrogen therapy with intermittent progesterone. Then artificial vagina needed. Growth hormone 0.05 milligrams daily for 5 years. Near puberty improves the height. Pregnancy can occur with the donor egg in IVF if uterus is present. Otherwise, they have to go for surrogacy. Coming to Klinefelter syndrome, genotype XXY karyotype, instance is 1 in 500 males, and externally resembles male. Features are unicoid appearance, small penis, small normally placed testes, gynecomastia, high-pitched voice, mentally abnormal, and sterility is the features of this case. So, frontal baldness is absent and tendency in grow fewer chest hair, breast development will be there, and female type pelvic hair pattern is there, small testicular size is present. Here in the poor beard development and narrow shoulders and wide hips and long arms and legs. These are the features of Klinefelter syndrome. Coming to the treatment of Klinefelter syndrome, here testicular biopsy shows hyaline degeneration of seminiferous tubules. So testes are not functional. Overgrowth by leading cells and sole to pubic length more than normal. Treatment is testosterone, breast excision. So it to do excision of the breast that is called, as they have gynecomastia, where to remove the fat and the gland to be excised. Coming to triplex syndrome, in this absence of baby, appearance of baby with this syndrome, absence of septum pellucidum in the brain is present. That's the abnormality, pathological abnormality. Though there is extra chromosome, it is compatible with survival. Features are patient is often mentally subnormal, scanty and irregular menstruation, and infertility are the features. Clinical manifestations are hypoplasia of genital tract. Then coming to virilism, characterized by hirsutism and some of the male appearances, atrophy of the breast. So hirsutism and some of the male appearances, atrophy of the breast will be seen. The chromosomal and gonadal sex is female. External genitalia resemble male. Coming to the clinical features, body masculine, deep voice, prominent thyroid cartilage, male distribution of hair. On examination, external genitalia hypertrophy of external genitalia, hypertrophy of clitoris, and fusion of labia majora. Vagina is often absent, and breast development. Breast underdeveloped. Varieties are adrenogenital syndrome, that is congenital and postmortem. Then the virilizing tumors like adenoblastoma, Hylas cell tumors, polycystic ovarian syndrome, and hyperthicoma. These are the conditions which are likely to cause virilism. Coming to adrenogenital syndrome, the adrenogenital syndrome is hyperplasia of adrenal cortex. It is of two types. Congenital due to the deficiency of enzyme 21 hydroxylase, excess output of androgens mainly 17 hydroxylase, and chromosomal pattern XX and hyperkalemia, hyponatremia are likely to occur. Diagnosis is by raised 17 ketosteroids and increased 17 hydroxyprogesterone. This is how we can diagnose adrenogenital syndrome. And coming to the treatment, we have to put the patients on prednisolone 2.5 milligrams daily and vulval abnormality corrected by plastic surgery. Coming to the next, testicular feminizing syndrome or androgen insecurity syndrome. The incidence is 20,000 to 60,000. 1 in 20,000 to 60,000. The testicular feminization syndrome occurs. This is due to absence and insensitivity of receptors for testosterone. Individual presents with female phenotype, genotype X5, testis seen in the inguinal region, abdominal region, ovaries absent, blind vagina seen, uterus is absent. Girls grow tall and attractive. Breasts well developed, excellent pubic hair or scanty, excellent genitalia are female. So vagina will be in the way of blind pouch. So by plastic surgery, we have to do recanalization of the vagina by putting a skin graft and making dissecting between the in between space between the vaginal and rectal space. A blind pouch we have to cut and create a space and create a neo vagina. This diagnosis of feminization of male genitalia, chromosome study X5 bar body is absent, and ultrasound absence of uterus and ovaries. LH levels are high, FSH levels are low. So, we have to treat them, removal of the testis and vaginoplasty, estrogen therapy. The treatment of this feminization of male genitalia, that is testicular feminization syndrome, removal of the testis because they are likely to turn malignant if they exist if they are not descended either in the inguinal region or in the labia. So vaginoplasty has to be done, a neo vagina has to be created, and estrogen therapy is to be given. Coming to the summary of management of intersexual patients is genetic, chromosomal, nuclear sexing has to be done. Genetic, chromosomal, and nuclear sexing has to be done. External genitalia examined and genital incision. And contrast radiography has to be done. And gonadal biopsy has to be done. And laparoscopic directed gonadal biopsy to be done. And ultrasonography to know where the testes or uterus and ovaries are formed or not. Then coming to the estimation of estrogen, 17 ketosteroids, testosterone, and 17 hydroxyprogesterone. Estimation has to be done. And estimation of electrolytes has to be done. And IVP for any renal anomalies. These are likely to be associated with other renal anomalies. So IVP has to be done. MRI for adrenal neoplasia, and psychological assessment has to be done. Thank you. Any questions you can ask? Any questions? Thank you.